Time for our three speakers to talk, and I'm going to say something about the person in the middle, whom I know very well, by the way. Our three speakers to talk with each other, and then we'll segue from that into a time when you will be asking the speakers questions. And Mr. Snow gets to ask the first question if he's here, because he was going to ask one of Elaine Waxman earlier, or make a comment, he said, which is fine too. And we want, when you do ask questions, we want you to make sure to grab a mic. And the reason for that is partly that we want to be able to hear what you say, when the speakers want to hear what you say. And secondly, that we want to get it on video, and if we don't get you on a mic, there won't be any kind of responsiveness from the question to the speakers answering the question. So, I do want to introduce Victoria Kumpuris Brown, who is a former Washington Lee student, and I'll say more about that tonight. She is also with the Robert Wood Johnson Foundation, and she's going to be our speaker this evening. And she's certainly a part of this conversation that's going on, so we're going to have the three of them begin with an exchange back and forth as they see fit, and then we'll segue to questions from you and comments from you. Okay? So, have at it.
So, okay. So, both of you, we try, from the child health perspective, we try hard to make the argument about the impact of child health over longitudinal health and how it's linked, it really is linked to adult health. And I can't say that that argument has been entirely successful or even partially successful. So, you know, as health providers, we think the health argument is very compelling, but actually I'm asking for advice. How else might we frame or additionally frame the argument of the impact of child health, the direct impact on adult health? How could we frame that in a way that might get more traction or attention, or what could we add to our frame?
You know, the thing that I know is that, and I have talked a lot about the rubric, and that I've worked on this issue for a long time, and I also have worked on this issue as I've become a young mom and a parent, now 2 children, and so it's been interesting to see how those 2 experiences have really coalesced and which each one brings me in each frame of my life. And I know that when you think about a child doesn't drive themselves to the doctor, and so when you talk to children and their families, you actually are impacting the whole health and well-being of the family, which is actually cheaper if you think in the mind of whoever's providing or paying for their insurance, be it what type of, if they're on a state exchange, if they're on Medicaid, if they have private insurance. And so if you are making an intervention around diet, health, well-being, and you're talking about, I'm talking about the kid, but mom and dad are gonna have to make some changes too, grandma, grandpa, I think that can be a more compelling sometimes argument.
I guess, and Elaine, maybe I want to ask you, because we do know this as pediatricians. If you take care of a child and you say to the family, in order for the child to get healthier, the family has to make change, and the whole family changes, the child health status improves, but the adult health status improves. But we haven't had a way to capture the family unit improvement. Mm-hmm. What were some thoughts you might have about that?
This is so timely. This is exactly what we've been talking about in the diabetes project that I mentioned earlier, because the food intervention is a household intervention because people don't eat individually, and especially if you have kids, you don't go, oh, that's my food, right? Yeah. Don't touch mommy's grapes, right? And so I think we haven't done enough to think about household interventions, and there's so many ways in which your family members or your significant others can either support or undermine, right?
Yes.
And so that's kind of the next holy grail for me in terms of community health is that we not think about the child, right? Yeah. Or even the family, but, you know, mapping out who are the influencers in your life and in what ways are they making a difference and how can they be engaged. Yeah. And as to your other question about how do we make the case, I don't know, it just makes me want to just slap my head repeatedly because you feel like you can make a good case. I think one of the things that's lost in the discussion also is when we talk about children, it's that 0 to 5 that's really key, and you did such a good job of showing that. But as you pointed out, adolescence is also a really pivotal point. And that is the immediate workforce, right? You guys you're still in that group. That's the productivity and the workforce and the people who will be paying for those of us who are getting older. And so I think sometimes we also need to remind people that when we talk about economic growth and productivity, if we're not paying attention to that second decade, the 10 to 19, that's an immediate detriment. So I think sometimes people think, oh, children, you can make up your health habits later in life. You can't, really. But I think I'm really interested in trying to make that other case.
And also there are parents, so to get impact on, to have a healthy family in preparation for having a child is incredibly impactful on that child. So if the mom's healthy, the dad's healthy, they have healthy habits, that really sets the stage for much of what's going to happen later. So, because that baby, when they get done their formula breastfeeding, they fall right into all those health habits that the parents have. So I agree, that stage is incredibly important.
I've been with my new employer now only since earlier this spring, and it came in philanthropy. I'm also new to philanthropy, but at a time when what is the country's largest public health philanthropy, really decided that they weren't going to be able to achieve their goals unless they had a much more ambitious mission. And so they reframed, they reorganized, which has been, I think, somewhat problematic for a lot of their grantees, but they both laugh. But their big goal has been around building a culture of health in the United States, and that for people to really achieve long-term health outcomes, their communities, not just the families, their communities, their places where they live, work, eat, pray, all have to be geared towards that overall culture of health, which when you think about it, it cuts across everything. It cuts across the way our streets are designed, our schools are designed, what we eat, what we do, how we exercise, who are our role models. And so when you think about that, to achieve real health, what that means, it is mind-boggling in what it will require.
So I guess I want to speak to all of you for a moment. I think that this is extremely important, because when you say culture of health or health of the population, you can do that with policy, you can make workplace rules, but it's ultimately a question of mutual respect, compassion, and understanding of each other, and why it's important for every person to have the opportunity for health and every person to be healthy. And in the places I go, I use the word silos, I see a lot of silos of people maybe never having met somebody in poverty or never having interacted with somebody from a different cultural background to the extent that would allow them to really understand the challenges and the issues. So the fact that you've gone out and you've really been building those bridges, I think, is incredibly important, because all of those structural things have to happen, but what also has to happen is those bridges have to be built between people, so that we really understand why we're all connected, how we're all connected, why we're all important. So again, I think what you've done this summer is so incredibly important.
And and this won't surprise Harlan or some of the other folks within the SHEPD program or consortium here. And I think Sandy's earlier point about what it means to be ethical and what it means that all of you here are recipients at all your colleges and universities of first-class educations, regardless of whatever you decide to go on and do, where you might be 5-10 years from now. The knowledge that has been instilled in you and what you're going to be able to achieve, you're luckier and more fortunate than most. And how that applies back to then your duty to give back, to show compassion, to be an active, vibrant member of your community that goes beyond what you do for your family, what you do for yourself, and that you've made that connection early on is something that you're to be commended, and we will all be the better for it.
Absolutely.
I suspect that's an invitation to segue and for you to begin to ask questions.
Let us have it.
All the speakers. And,
More comments?
and Trey, you get to go first.
Yes.
I
We want to make sure that whoever has the question has a mic in their hand.
Any thoughts or reflections?
Or comments?
Comments?
I kind of got a question.
You introduce yourself, Sam.
So I'm Sam. I was in New York City at Code Interactive. I have a question regarding the diabetes situation. You have children growing up with diabetic parents all over the United States. And these children, they see their parents eat this certain food. They eat healthy. But they also tell their children, no, that's mommy's food. Mm-hmm. That's what I eat. That instills a bias in the child. So not only do they recognize that as mom's food at the time, but they also recognize it as mom's food years down the road. Mm-hmm. So how do you combat that bias to allow them to eat healthier?
So I think this goes back to our overall change in thinking about what it means to be healthy, right? And I think one of the things our processed food world has done is it's segmented child food and parent food in a really weird way, right? I mean, you can probably speak to this more than anyone, but you know, it used to be that when you were little, you ate whatever your family ate, and you didn't eat out of a jar, and you didn't eat chicken nuggets with, you know, the Happy Meal or whatever. And so I think part of it too is that we developed a siloed food culture, and it helps for us to all get back to an investment in, no, this is what we all do, right? I eat this way at school, I eat this way when we go out, I eat this way at home, and then you start to move away from the, well, that picture over there is the unsweet tea for the diabetics, right? You know that if you're from the South. And so this is, I think, back to this culture of health. We need to own this collectively and not have segmentation the way we have. And, you know, part of that is on our marketing too, right? There's a lot of marketing aimed directly at kids. There's a ton of marketing. You guys are like the holy grail of, you know, advertisers as well, because you've got spending power and you're about to get more, hopefully. And we have to be able to disrupt some of that. And it's hard because there's a lot of money at stake in those decisions.
So I'll also say that we did focus groups among parents of children under 5 all across the country just to sort of test some of the messages we were giving them as pediatricians. And they, uniformly, parents were astounded to learn that even the youngest children looked to them as role models. It was something that we might take for granted, but they were just very surprised. Oh, the baby's looking at me, the 1-year-old's looking at me. So one is just the impact of health and disease and the importance of good health, the impact of the parent as the role model. Many parents that I talked to in that situation felt that let's back up a step, that the children were really in charge of choosing what they ate in many families. So when I asked a mom who had teenagers and I said, how do you know what to cook for dinner? She said, well, they decide. I said, well, what do you mean they decide? They're 13 and 14. Well, one day the 13-year-old says what they want, and the next day the 14-year-old, or the mother of a 5-year-old, and the 5-year-old is getting their own snacks and demanding their own food, or the classic mother of a 2-year-old. I love this 2-year-old. The 2-year-old would run up in the grocery store and grab chocolate or the cereal she wanted. When the mother tried to put it back, she had a tantrum, and I mean a tantrum, screaming, kicking, yelling, and the mother, to get out of the grocery store, gave her the food. So we have a 2-year-old who is in control of the food environment. So the other issue is making the link between health, good health for everybody and the whole family, helping the parents understand they're really role models, and then helping them to sort of get back in charge of being the person who really is making a health decision when they decide about nutrition or physical activity. That's really a health decision. And sort of getting that decision out of the hands of the 5-year-old or the 13-year-old. So there's a lot of parenting, teaching that we engage in all the time to try to reset that mentality, in addition to the societal things.
And just to layer on top of it, and I think when you think about where we got today, and if I think about why I've been sort of engaged in this issue for as long as I have, it's both the intellectual exercise of it is fulfilling. You know, we're all smart people, we're interested in things. It is a fulfilling issue because of its complexity, because of how it cuts across so many things. Again, the way we live, work, eat, eat, pray. Everywhere we go is how we got to where we are today and how much has changed. And so if you think about what that requires, then for down to very individual, relational, mom to child, this is how I'm doing, back to what's available, they each are building blocks. So mom might be prepared to have the conversation, but then if she walks into the store and she's barraged by all these advertisements, that it's you have to address all the different things. I think where my work, and I'll give a commercial, is how you can be practical and pragmatic about mom's got to go to the grocery store. McDonald's might be a regular reality for me. It might, I might only have a certain amount of food budget to work with, but let me make at least those choices a little bit more something I can live with. And so which way, how you handle all that. So I think there's a lot of layers into what you're saying.
There's a question right here. Please get the mic. And introduce yourself.
Sure. Hi, I'm Sarah Whipple. I teach developmental psychology here at VMI, and I study cumulative risk. So this was all very interesting to me. First, a comment I noticed in your talk, you mentioned wording was have obesity or have overweight.
Yes.
And I picked up on that instead of, traditionally we think of are obese.
Yes.
And I know when I talk about mental health, I teach intro psychology as well, that I try not to say are schizophrenic, but have symptoms of. So I noticed that, and I'd never thought to use that when it came to obesity or physical symptoms.
Yeah. Let me just comment on that. We are really trying very hard, or I'm trying very hard, and those of us in the pediatric community, to really use people first language. So really say the person who has obesity. For many of the reasons that you alluded to around mental health, because the prejudice about obesity is so strong in our culture, it's so very strong, that I think you actually, if you find you have to actually consciously be thinking about using people first language, so the child who has obesity. The other reason is obesity is a disease. And so we have to really be cognizant of that. It's not a label that you put on people. So I think it's just the evolution of thinking, and thank you, because asking everybody to be conscious of just using the people first language when you speak about obesity. So thank you for that point.
And then just a question. I really appreciated the incorporation of the psychosocial outcomes, depression and attachment and whatnot. And I'm just curious because I think that parenting is very important and teaching kind of best parenting methods. I'm just curious, what is the best way to do that? Because it can be such a sensitive topic to parents to potentially criticize what they're doing. Even good parents get defensive when you mention, that they're doing something incorrectly according to the best practices. So should we do this in high school? Should we have child development classes instead of, just thoughts on how do we teach parenting?
Well, I think it's really good to just raise the question of teaching parenting, because we don't teach parenting. Parents just happen upon it, either by how they were parented, reacting in a positive way or negative way. So I think teaching it is important. I think the community has I think there's a role here for the culture of positive parenting, a culture of parenting that works well for people. We don't, we're free, it's easy to criticize the parenting, but at least when we teach the pediatricians to talk about it, we use a lot of training. The pediatricians use motivational interviewing and eliciting a concern. Most parents, when things are not going well or the child is having problems or they're having problems, in a conversation, if you are open, will tell you about that. But I think culturally, we don't have, we're quick to point out mistakes that parents make, but we're not so quick to point out what are positive parenting skills, and we're not so quick to look at the family unit as a unit in need of skill development. You know, we somehow think that they just either will haphazardly acquire the skills they need to be healthy. So I think there are many levels of intervention we could think about.
So this, I've just noticed there's an interesting trend because one of the former, oh, sorry, my name's Emma Jackson. I was in DC for the summer. I noticed that there's this kind of dichotomy between, I know that one of the former speakers was talking about how as more children have become overweight, it's also been that you would think that the harassment would stop, but in fact kids have been bullied more. Well, recently in the media, there's been this, what some people are calling a fat acceptance movement, and people are just kind of being really proud of their bodies. And on one hand, that's really good because, you know, you're saying, I'm okay with myself, and like, as a good point to move forward, but would you think that that ever becomes a negative thing when people are severely overweight or obese, but their, like, culture is becoming accepted to it? It's, like, what I'm trying to say is, do you think there should be a defined difference between understanding you're not in a good place, but like being happy, being not healthy? Like, I guess that's what I'm saying. Do you see this becoming a problem?
So I think this sort of reaction is an outgrowth of all the blame that we've put on people. So I think that the more we can identify obesity as a condition that you have, just like you might have asthma, right? Then the more it keeps people from internalizing that and thinking of themselves as being the problem. They may have a problem with their health, but they are not the problem. So I think one is shifting the conversation. Two is looking at high-risk health behaviors, because there are people who do not have obesity, but have high-risk health and nutrition and physical activity behaviors that when we put the expert guidelines out for childhood obesity in 2007, we said everybody needs prevention, because if this doesn't stop, you may be at a BMI that's considered normal now, but if you have high-risk health behaviors, you're headed in that direction. So I think two things, at least two of the many things you could do, is shift the conversation. You have obesity, you are not the problem, you have a problem. And who has high-risk health behaviors? Most people do, that are in need of some attention, so it gets to that the risk behavior profile rather than what you look like.
I'll say one more thing, because it cribs on Harlan, what you said at the break. You know, there's two levels of this. So I think your question is a good one, but it applies to sort of the flip of the personal responsibility lens, like bad, but I'm claiming it, you know, it's okay. But then you could also look at it that on top of it, and Harlan mentioned this, you know, there's trends right now that are saying obesity is declining, but we were all joking, you know, I don't think any of us are going to be out of talking points anytime soon. And you go back to, cuts across every aspect of society. And so regardless if you're struggling with obesity or what is happening, you have to keep in mind that a lot of this, it isn't because I decided I let myself go, or I did this, or I did that. It's because of the neighborhood I grew up in, the absence of choices that I had, the lack of physical activity because it wasn't in my schools. I couldn't go out and play because it wasn't safe. And so it wasn't that I had to choose it one way or the other. And so when you take that, and I'll look at you guys as college students, you know, it becomes almost a social justice issue. Mm-hmm. You know, how did this happen? How did this happen in my community? Why am I being marketed or spoken to like this? And so I'd say to not forget that aspect. This is something that has happened to us. It's a country versus that just singular, right. I was able to make my choices, and that's where I went.
And I just want to say thank you for that. And you know, obesity is a disease, but you can also consider obesity and food insecurity symptoms of what is not going well for children. They're symptoms as well. Yes. So they're conditions, but they're symptoms of a broader issue of a real societal will to look at the population and value the health of the population. if we valued that to the extent that we could, we know what we would need to do.
Nancy has a mic, and somebody else wants to claim one right there. So Nancy, you go first, and then I can't even see who you are from here, but I didn't recognize Nancy.
Hi, I'm Nancy. I was up in Vermont doing work with a weatherization program this summer. Actually, what I wanted to talk about is on this very same vein, so it's very convenient. And that was the attitude people have towards people that have obesity, and the way they're spoken to, and how that affects them. So that blame that gets put on them, and even in family settings. So how do we kind of work towards changing that rhetoric and making families understand that if you're ridiculing your child, that's probably going to have adverse effects on their weight, rather than the positive effects that you're hoping, that.
So some families do that without thinking. Some families do that due to the bullying or the ridiculing because they think that's a motivator. So simply saying to them, that doesn't work, that's not a good technique. Is it helping? And they'll say no. I said, well, it doesn't help. So within the family, I think that sometimes it's lack of parenting. They need some more skills to manage the situation. So in order to, sometimes they feel if they just sort of speak that way to a child, that'll motivate the child will fix the problem. Sometimes they need more skills to understand the family system and the parenting choices and actions that they could do. So I think, and again, I think this is a societal problem we are having with labeling people. This is a societal problem with labeling people and blaming people. And at that level, I think we have to take a run at it in all of our conversations. We have to write about it, we have to speak about it, we have to shift that dial about blame. Because I'll tell you, when I go up to Washington, this isn't just about obesity. There's a lot of blame. We blame the people for being poor. We blame people for being, like you said so eloquently, the deserving. You have to deserve help, right? Otherwise, you're blamed, right? The flip side of the deserving is you're blamed for it. So we have a problem in this country, and the problem is with blaming. Again, I think it's the problem with not understanding the other and not understanding that we're all, I was again at the Senate hearing, and one of the people that works with disabled people said we're all 24 hours away from potentially needing the safety net if something happens, and that realization hasn't hit. So it's a sense of community that has to be strengthened, and the sense of the connectedness between us.
Next
Hi.
person. Yeah,
Hi,
and don't forget to introduce yourself.
I'm Elaine, and I was in Atlanta this summer. And so my question for you guys is that in your conversation and advocacy efforts for food insecurity and reducing that in the country, is there any conversation about the ethics and sustainability of the food that you would like people who are facing food insecurity to have access to? So like, we didn't talk about meat, but antibiotic-free meat that's ethically raised, or the ethics behind how people are growing the food, the ethics of how the growers and the workers are being treated, because I think that matters.
I can speak to that a lot from our conversations that I had in a former life and in my current position with big food suppliers, both manufacturers of processed food on their shelves, also major restaurant systems like a McDonald's. And so you take a McDonald's, when they decided to give apples, it's best, they had to make sure that literally there were enough apples in the food supply so they didn't have the negative externality of depleting the world's supply of apples. They developed a shrimp salad when I was in conversations with them that they could not introduce because it would have run out of shrimp for the rest of us. And so that there are serious issues around how they can provide fresh food when they could deplete it on the outside, they overwater, overuse. So I think the sustainability faction for fresh food is critically important in food insecurity and obesity. Where in my work, what we're still trying to catch up is then you have the issues of GMOs, genetically modified ingredients. Then you have should you have artificial colors, or should I have artificial flavors, or should I go all organic? And those are all important issues. They're ones that I adopt in my home, and I'm able to. But when you get to baseline issues of, I'm thinking about what I'm going to serve in a school cafeteria and how I need to open up the food supply so that I'm a food service director for Atlanta, Georgia, and I can buy enough lean meat chicken patties to feed everybody that's cheaper than the full fat hamburger patty. I got to first figure out that kink before I can make sure that they're all antibiotic free and organic. And so there's layers to the conversation. I think probably the first one in my experience has been the sustainability issue of water and making sure that there's actually going to be enough is intersected. We're not yet to the point where I've seen where you can also layer in organics, antibiotics quite yet. But I think with the antibiotic issue in particular, I think where, again, I'll go back to the social justice aspect of things, is as consumers, more and more, and with the power of the internet, and particularly as it relates to food, there's a lot of power in your advocacy as individual consumers, as savvy users of social media, that say, I'm not going to go to your restaurant anymore because you have antibiotics in your chicken. You get a couple of things going on the internet before you know it. Chipotle, Wendy's just announced it last week. McDonald's has made the shift with their chicken. And so there are things that you can do to help push those agendas too, but the connection back to, I think, and I'll let the researchers here speak to the research implications, and I think you will find emergent coming out that those things do impact obesity, but talking about availability, it's a layered discussion.
And I just wanted to thank you for raising the worker issue. Yeah. Because it turns out that in the top agricultural producing counties in America, they have some of the highest food insecurity rates. So people who actually, grow it, pick it, pack it, whatever, eat really poorly and can't afford often the kinds of things that they're actually growing. In those areas, in those farm worker areas, there's often very little in the way of grocery stores or infrastructure. So, it literally starts where the food comes from. And this is in some ways, tied to the complicated issue of cheap food, right? I mean, there's always costs, right? And if we want cheap food, then we don't pay workers so much. But that has a cost for other people. So that's also part of the conversation, I think.
Yeah, and I just want to bring up the food waste issue, because we have a culture that doesn't, for example, if you walk into your grocery store at 10 o'clock at night, we all have the expectation that all the bread shelves will be full, right? And we will have plenty of produce to buy. So many of the use by dates are very early. Food is thrown away. The rotisserie chicken, if it's there for more than 4 hours, is thrown out of the grocery store. So we have a big issue all along the food supply chain with sustainability, but we also have a huge issue here with food waste and the cultural expectations of, big portions. Now, somebody may eat that whole portion, but you may not eat that whole portion, and that will be thrown out. So I think that, from the beginning to the end and the closing the loop with food waste, these issues reverberate around that whole cycle.
Nancy, you have to tell us who you are, too.
I have to do what?
Nancy Shepard has to tell us who she is.
I'm Nancy Shepard. And Elaine, I feel almost a little ignorant asking you this question, but when you referred to diabetes, is it specifically type 2 diabetes that you're talking about?
That's where it's been the explosion in growth is type 2. Some of these issues are relevant for type 1, but it's really a very different illness in many ways, and Sandra can speak to that more eloquently. But yeah, the explosion in the diabetes epidemic has really been in type 2 and very much driven by the things that we've been talking about. What's really extraordinary is that the CDC projects, based on current trends, that kids born in the year 2000 and later, 1 in 3 will develop diabetes. And if you're African American or Latino, it's closer to 1 in 2. So if you think about that, that is profound, right? Because the complications and disabilities that can play out over time, get right to people's ability to, learn and work and parent and be part of the community. So it's potentially a huge shift.
I will also add that type 1's increasing. We don't know why. So that's also increasing. And we know a lot about why type 2 is increasing. We don't know why we're getting that increase. And also that it seems like the trajectory of the disease development in children is moving faster than it's moving in adults. So from having impaired glucose tolerance with pre-diabetes to diabetes, looks like it might, if untreated and unfocused on, might be 2 to 3 years in a kid, which is very fast. And then end organ damage, your eyes, your blindness, kidney failure, and all, if untreated, is about a 2 decades long process. So you can see that that trajectory for a child who gets type 2 can be very devastating and rapid. So again, we're not sure why it seems to be sort of moving faster in a kid.
It's here anyhow, Tom Shepard. Is it too early to tell about the favorable effects of the Affordable Care Act in terms of what's happening to people, diagnoses and that kind of stuff?
So we're about to have a really interesting natural experiment, I think, in some ways, at least for low-income communities, because we have about half the states that have taken an expansion under Medicaid to, reach out to low-income communities, about half that haven't. And so I think that will provide us with some opportunity for observation. What's really interesting in the case of diabetes is that in the states that took the Medicaid expansion, there was a significant jump in the diagnosis of new cases, right? In a very short period of time. And that jump was not repeated in the non-expansion states. So what that tells you is it is getting people into the system potentially for earlier detection, and as you just said, or any detection, right? Even if you're far down the illness spectrum, there's always something you can do with your health. And I think that's really compelling. It's a really important point too, because we're sending all of these health messages to people, and frequently they're not equipped to do the things that we are expecting them to do, right? If you have morbid obesity, you need the help of the healthcare system. But if you have, if you don't have insurance, or if you have co-pays that stand in your way, this is where structure influences behavior, right?
And the only thing I'd add on is the Affordable Care Act goes beyond the medical. So there's also the requirements about menu labeling, and what you will see, I think 50 restaurants or more, that they'll all have their calories posted. Now, we don't know if that's going to work, if it won't, but those will be experiments that we'll also get to see what that might do for the overall health and well-being and knowledge base of the population.
Kirsty Klein, and I worked in Helena, Arkansas at the Delta Area Health Education Center. So I know that some of these big food companies that sell a lot of fast food and processed food have contributed a lot to obesity in America. So in your opinion, as public health advocates, do you think that it's more effective to fight these companies like we did with the tobacco industry, or do you think it's more effective to create partnerships and relationships to address obesity?
That's all I do. I think it goes both ways. I think there was a time when impassioned advocacy, like our friends at the Centers for Science of Public Interest, who are the best at it, that they needed to raise a level of awareness about what was happening and get people angry and outraged. And that anger and outrage can drive things to a certain level. But again, I'll go back, and this is my own bias and belief, that we got here because it cuts across everything. Everything. The people that are making your laws in Capitol Hill and at your city hall, where you go to school, where you go after school, what mom's able to do, what dad's able to do, what I can buy at my grocery store, where a grocery store is zoned, what might go into the grocery store. It cuts across every single thing. And so a societal problem that complicated, that multifaceted, Sandy had a great slide. It showed every single stakeholder. I would argue that it would be so much easier to say bad guys, good guys, I got it clear, I know what to do, But I don't think it's that simple. I would argue that there is a role for everybody to play, and that there is motivations by a lot of those big food companies because of the fear of regulation that you should take advantage of.
And I'll also say that all companies have employees, and they have to foot the bill for their own employees' health care and that of their families. So the other conversation that I think we are having, increasingly need to have, is their vested interest in the health of their employees and families as a way of getting that conversation started. I think that there's this, I agree completely with Victoria, it's going to take all of us. It's about how to have those values-based conversations and get to and understand the drivers on each side, but get to the place you can get to make change. And those conversations are much more complex and much harder than just saying, no, I'm not going to speak to you, or I'm not going to speak to you. Those conversations that you have are hard, but they're conversations we have to have.
I think we have time for one more question so that we have time to get some rest and come back and hear Victoria tonight. So here it is.
I'm Wesley St-Hilnor, and when we think about obesity and health problems, I like to think about how we fix things and what the policymakers would do to help combat all these problems. And I was kind of puzzled by the use of deserving poor earlier, and I was wondering what's the fate for the undeserving poor?
I'm sorry,
Or whatever that may entail. I think the use of deserving poor, whatever that means, and what would be the fate of the undeserving poor?
So, you know, that language is something that we have had in our collective DNA since this country was founded. And in fact, it goes back before us to English poor laws from where we came. Of course, we all know people in our lives, wealthy or not, who, you know, are a bit unmotivated. But the vast majority of poverty in this country is highly structural. It has to do with race, and it has to do with economic choices, and it has to do with all kinds of things that we are collectively a part of, right? But we have not accepted that because we are very much in this country about individual responsibility and individual success. And we don't like to talk about something that runs counter to our national narrative, right? The story is if you work hard enough in America, you can make it, right? I don't know about you, but people in low-income communities are some of the hardest working people I know. I mean, crazy hard. And so this is part of the conversation we started, I think, at the beginning with the shaming and blaming. That extends right up to our rhetoric around poverty and responses to poverty. It's not helpful. You know, we've been trying to shame the able-bodied poor for 250 years, and poverty is with us and, you know, and growing. So I think we need to collectively say that's not acceptable narrative. It doesn't, as you said, we'd like to think about what might make a difference. And we need to own the fact that our health status in this country is actually worse than a lot of our major global competitors. And it's all about the social determinants of health, right? So when we talk about global competition, we don't talk about the fact that so many other major countries, and some that are, you know, not as big a players as us, have better health outcomes than we do. Why is that? You know, this is the conversation we need to have. And it's just not very helpful to continue the blame. And that's part of why I always put that in my talk, because I think we don't realize how much that's in our political DNA. It's going on right now in the political election, you know, and it's pronounced in some candidates, but you know what? Both parties own it. You know, it's not a partisan thing. Collectively, as a country, we've not matured in our ability to talk about poverty.
I take this opportunity again to thank Elaine, Victoria, Sandy. They will be here And Victoria, we had the privilege of coming to hear her tonight, so thank you guys very much.